actually right here. But basically, this will often be maybe give or take, depending on the patient's dose, about a month's supply of insulin. Then you, as far as diabetes, again, it's a little bit more of a algorithm, whereas type 1 diabetes, you're pretty much treating 100% of those patients with insulin. In type 2, adult onset, you will typically try to, at least initially, or in their pre-diabetic phase, manage things with a lifestyle diet. When you do establish a diagnosis, it will be important to start something. Most patients do not go directly to insulin with type 2 diabetes. They will often use one of the oral drugs, although some of the GLP-2 agents are increasingly being used earlier in therapy. You'll often go with combinations of medications once the patient's disease progresses to where oral drugs aren't sufficient. And then later in the disease course, they may require insulin. So again, type 2 diabetes is a condition that's characterized by impaired glucose tolerance and insulin resistance. So these individuals are able to make insulin, but they will have persistently elevated blood sugars, despite that, both after meals and between meals. And there's a blunted response to insulin because of insulin resistance. An insulin spike, it may actually be more insulin in the circulation compared to those without diabetes. So it's deficiencies of insulin is not always a problem, but the glucose response is going to be part of the issue, and very often they have elevated levels of glucose as well. So we have a lot of different ways that we can manage blood sugars in type 2 diabetes, again, with the understanding that there is still some capacity to produce insulin, so we can use drugs that can kind of help the pancreas along as far as making and secreting more insulin. Sulfonylureas and the glutamides, the first two classes of drugs we'll talk about today, will work through that mechanism. But then also, because of insulin resistance, the key thing is to improve the body's ability to utilize the sugar that's in the blood. We can modify the ability to uptake glucose into the muscle and the liver through the use of 5-guanides and thiazolidinediones. And then with the absorption of starches, using alpha glucosidase inhibitors, they work locally in the GI tract. Don't use those much, but we'll talk about those briefly. Really, probably one of the most important breakthroughs in the last 10, 15 years are the incretin mimetics. They work through multiple mechanisms to help control blood sugar. And then finally, at the kidney, we can use SGLT2 inhibitors to decrease reabsorption of glucose from the renal tubules. So if you look at that from that broad perspective, a number of different mechanisms we can rely on. So this is kind of for your visual learners. We can look at it from the standpoint of, okay, the brain and behavior, how much food intake takes place, and incretin mimetics. We talked about pramlintide a little bit last week, and then some of the behavioral interventions, the lifestyle modifications, they will affect appetite and food intake. At the level of the muscle, exercising incretin mimetics will help take more glucose out of the blood and have it utilized by the muscle. In the liver, thiazolidinediones and metformin work at that site, as well as in the GI tract, the carbose for starch digestion, and then our SGLT2 two drugs for increasing excretion of sugar through the kidney, decreasing the reabsorption back into the blood. All right, so again, sulfonylurea is our first group of oral drugs we talk about today. They have been produced in kind of two waves. The first generation really are, you can get them, right, for clopropamide, I believe still, but they're not marketed. They're not really widely used much at all. They are very long-acting drugs and low-potency drugs, and really more for historical interest than anything else. Second-generation agents are still very much widely used. They have the advantage of being much more potent, much fewer side effects, and they give you a longer duration of action despite having a shorter elimination half-life because of their how they work on the receptor level. That includes glimepiride, amaryl, glipizide, fluvitrol, and glyburide, diabeta, or mitin. So think back last week to the process we talked about in terms of insulin secretion. And really, this will inform of that. So again, insulin and potassium are closely related in these pancreatic beta cells. Potassium is part of the signaling process, and sulfonylureas that block that potassium signaling will tend to keep potassium inside of the cell, makes the cell depolarize relative to the environment that it's in. That will then open the calcium channel. Calcium then will have these granules pushed. So sulfonylureas, again, at that first step of the process, the potassium efflux will be blocked and sets up an environment there, therefore downstream for insulin to be released. A secondary effect of that is that you will see lower glucagon levels because when you have more insulin in the blood, it increases somatostatin, which is a kind of global secretory, anti-secretory hormone. Sulfonylureas, generally speaking, are extensively metabolized in the liver and excreted in the urine. They're highly protein bound, so that can be relevant for certain protein binding interactions. And they're they can cross the placenta. Not the best drugs, but certainly wouldn't be considered completely unsafe if you absolutely had to go with like surgical approach, gestational diabetes. For gestational diabetes, by the way, we prefer either metformin or insulin. So again, the oldest agents, they're extremely long acting. They have all sorts of side effects. We just order them. Of the newer agents, glyburide is the most likely to cause hypoglycemia. Glimepiride has some of the beneficial insulin sensitization effects that we associate with other drugs like metformin. And glipizide has the shortest half-life. So, you know, they're a class of agents. There are some key differences within the class. These again are secretagogues. They secrete insulin. So you would expect side effects to be according to that. They can cause hypoglycemia. Insulin tends to cause weight gain, so these drugs will cause weight gain. They have some immune sensitization effects with people, for example, with sulfa allergies, etc. And there is a secondary failure that occurs over time as type 2 diabetes progresses. the insulin resistance may be too much for these drugs to overcome. We don't use type 1 diabetes, and they're contraindicated in DKA. In pregnancy and breastfeeding, again, it's a relative contraindication because they can cause hypoglycemia in the fetus. Again, it's absolute contraindication per se. And the interactions that kind of mentioned or implied the protein-binding connection, hyperglycemic drugs, anything that has to raise the blood sugars will increase the effectiveness. And they do cause a disulfurine reaction, the alcohol with alcohol flushing reaction. The meglitinides likewise are insulin secretagogues. Okay, they will work very similar to the sulfonylureas. The key difference, though, is that the sulfonylurea drugs are intended for kind of maintenance therapy over the course of the day, making sure to help produce a more consistent basal insulin secretion, whereas meglitinides are strictly mealtime drugs. So here, again, very similar, potassium channel blockade in those beta cells will increase insulin secretion. These effects are relative to the glucose level. So if you have a large glucose load, you will have more insulin secretion. You have a lower glucose load, less. And these peak effects are seen within an hour, and it's cleared. Both drugs are cleared relatively quickly, so they are definitely suitable as a kind of a prandial therapy. They are recommended to be taken in case of repaglinide, 30 minutes before meals, repaglinide 1 to 10 minutes. The effectiveness peaks in about an hour, works for about 3 to 4 hours, and that's it. It's clear from the body. So really, they're classically a mealtime agent, and if you miss a meal, you should skip the dose. Pretty much avoid taking it if you're not. These agents can be used with metformin, but it's not recommended to be used with other oral agents. So there's that. Here are the adverse effects. Again, minimal, only because the effects are very short. And again, the risk, of course, is if you have, you take it with a very small or without eating at all, you can the drop in the blood sugar. So you will be eating a little. Take those things.
I don't think your slides are advanced.
Yeah, all right, so that's the adverse effects. I mentioned a couple times already metformin. Metformin is probably one of our most important oral drugs for type 2 diabetics. It's in a chemical class called the biguanides that include buformin and fenformin, but neither one of those agents are marketed in this country. So really, talk about biguanides in the United States, it's metformin. Branding is glucophage. And there's also a huge number of combination products, because one of the features of glucophage, metformin, is that it really works quite nicely, quite synergistically with drugs from other therapeutic classes. So you have glucodance, which is metformin and glyburide, and metaglip, metformin and glipizide. And then other combinations with metformin with drugs that we'll be discussing a little bit later. So that includes SGLT drugs, thiazolidinediones, as well as okay. So we'll touch on all of those other drugs, but let it suffice to say that metformin, because of its mechanism on the liver, on muscle, then it's not a secretagogue. It really does play quite nicely with other diabetic. So again, they work in the liver to decrease gluconeogenesis, and in skeletal muscle to enhance glucose uptake. Type 2 diabetes, again, is often a issue around insulin sensitivity. So the bioflavonoids help with that factor as well, by increasing insulin binding to its receptors. You get less glucose absorption from the GI tract than you would normally. Part of the reason is because it causes diarrhea, and a lot of people have problems just tolerating the hypermotility you get from it. But overall, there is less glucose absorption, so you have that. It is not, however, a secretagogue, does not increase the amount of insulin that's secreted from the beta cells. So with that, you get less of a risk around hypoglycemia. So in monotherapy, really, we consider the risk of hypoglycemia with metformin to be 0 to minimal. Really, it's very low risk because really it's just utilizing the sugar and the insulin that's already in the circulation and really not promoting any additional secretion from the pancreas. So that's really part of the reason why this is one of the better approaches for diabetes, for type 2 diabetes specifically. All right, so metformin is actually not metabolized in the liver, although a lot of its pharmacology takes place in the liver. Its kinetics is independent of liver metabolism. But we do have to avoid it in hepatic disease, and I'll get to this issue around lactic acidosis in a little bit. It is excreted unchanged by the kidneys, and we have to be especially careful in advanced renal disease, which of course is a complication of diabetes because of the fact that metformin can accumulate, causing this issue, lactic acidosis, which can then be problematic. So where is its role? This would be one of our first line oral drugs, type 2 diabetes. There is some data in pre-diabetic patients with impaired glucose tolerance who are not fully diabetic yet, that metformin can prevent that progression. So I would say it's a effective agent as well for prevention in your high-risk pre-diabetic patients. Definitely good for obese patients with insulin resistance and hyperlipidemia. Some favorable effects on lipid profile, weight. It's an alternative to insulin in gestational diabetes. Its profile is good for having no weight gain, perhaps some weight loss in some patients, and beneficial effects on lipids. And again, because of its unique pharmacology, they can be used in combination with other anti-diabetic agents. So very widely used for agent for a number of reasons. Does carry some baggage, however. The key side effect is the GI, especially early in therapy. It can range from an unpleasant taste in the mouth to anorexia, reduced appetite. The GI, lower GI can be pretty serious. It can range from constipation to diarrhea, to heartburn. And there will be a percentage of patients between say 5 and 10% that just cannot get the GI tolerability and really won't be able to keep them on for a period of time. Some patients will develop a rash. There is a interaction in terms of vitamin B12 absorption, which in turn cause a megaloblastic anemia, macrocytic anemia because of low B12. Weight loss, which is mostly desirable in many of the type of diabetic patients, so there is a side effect. And then you have this lactic acidosis. So basically what happens with metformin is that it interferes with the metabolism of lactic acid. This is a byproduct of skeletal muscle activity. You have that lactic acid burn when you exercise, for example. And when that, although it's associated really more with the other bipronines, metformin can still have that. Risk factors for that include renal impairment, elderly patients who take metformin after being on oral contrast. If you remember from last semester, contrast and induce a temporary nephropathy. And we have to make sure that we, hydrate those patients, get those kidneys flushed out. Contrast can impair the clearance of metformin, so there's that. Alcoholic and compensated hepatic failure, hepatic metabolism is not relevant to metformin, but the compensated hepatic failure can get added as a worsening of acidosis. So we say that metformin is contraindicated in GFR less than 30 mils per minute. It used to be where we say, well, if your serum creatinine is greater than 1.5, 2.0, whatever, it would be based on that. But now, within the last 10 years or so, it's changed into GFR less than 30s. Also contraindicated in existing metabolic acidosis, and compensated liver disease, and then with drugs that compete with tubular excretion, for example, oral contrast. And in certain surgical procedures, it should be stopped as well because of the potential for lactic acid buildup. So if they get past the GI tolerability issues, if their kidneys are healthy and you avoid any issues around these interactions, and that sounds like a lot of ifs, but really most patients do quite well on metformin, at least as an initial practice. All right, next, yeah, sorry.
For the contract, I just want to
Good catch.
Good question. I think the recommendation is specifically for oral contrast, but I would imagine iodinated contrast, even if it's IV, would be a problem as well. So I would assume, and I could be wrong, but I would assume that any iodine containing contrast, whether it's oral or IV, would slow the kidneys down enough to accumulate metformin. That's wrong. I will follow up.
I can answer that.
I'm sorry.
I can answer that.
You can.
I can.
Okay.
So it used to be thought that it was. There's a lot of evidence now that says that they used to IV hydrate the heck out of these people prior with iodine contrast, which is all IV. And then, so because there was the thought that it did cause renal insufficiency or acute kidney injuries. But now they're saying it doesn't. But there's still people who will say, oh, metformin, no. So you kind of have to walk a fine line right now, and it's whatever is the protocol at your institution. I think it's still safer to err on the side of caution.
Yeah. And it's not like insulin where you stop insulin, or, insulin in type 1 patient where if you stop it, you get into serious trouble right away. So I'm holding metformin for 48 hours or whatever. It's not as, the downside to that is not as risky. All right, thiazolidine diones. That's a mouthful. Really, the one drug in this class that's relevant anymore is pioglitazone, Actos. Rosiglitazone and troglitazone, that's a throwback. Those two agents were the first two on the market and have since been removed In the case of triglyceridone, because of liver toxicity, and rosiglitazone has had an issue of edema causing congestive heart failure. Pioglitazone, to some degree, has some of those liabilities of both, but not nearly as much as the others, and certainly not to the point where, at least yet, it's had to be removed from the market. So pioglitazone, how it works. It is an agonist for a receptor called the PPAR gamma, peroxisome proliferated activated receptor gamma. This is an adipose tissue, skeletal muscle, and the liver. And again, this is on the side of insulin utilization and glucose utilization. So what this will do, almost kind of like a intracellular steroid receptor, where it goes to the level of the genes and DNA to increase the production of gene, or increase the activity of genes that code for proteins that's involved in insulin, lipid and glucose metabolism. So remember last week we talked about the various glucose transporters, group 1, group 2, group 3, 4, 5. Specifically, what the thiazolidinediones do, they will cause a downstream increase in the expression of group 1 and group 4. Those are transporters for glucose involved in adipose tissue, skeletal muscle, and the liver. So by increasing the level of those receptors, the expression of those transporter receptors, you are kind of pulling more sugar out of the blood, having it used by those end organs, and having a favorable effect on the blood glucose profile. So as a result, you get improved insulin sensitivity and less insulin resistance. So you get a improved glucose uptake and utilization, and a diminishment of hepatic insulin production. It's metabolized through the liver, highly protein bound. And because this is a process, it works through the genes, you have to increase the expression of these proteins, etc. You may not see the maximal effect for several weeks. Now, again, because of the issue around edema and congestive heart failure, rosiglitazone was removed from the market. And likewise, pioglitazone can cause some of that, you get edema, heart failure, but again, it's just different levels to it, not as bad as with the other agent. Other side effects include headache, fatigue, muscle pain. You can gain weight on this, and you can get a little bit of hepatic toxicity, as you did with the original troglitazone. Now, there's also the primary pharmacology is the PPAR gamma, but pioglitazone also happens to activate another receptor called the PPAR alpha, and that's responsible for some of the lipid effects of this agent, which actually happen to be quite beneficial. Remember, HDL is your good cholesterol, and a result of this PPAR alpha activation, which is really kind of a aside, not really the primary pharmacology of it, but you will get an increase in HDL, excuse me, and a reduction in triglycerides. So those are, good lipid effects. You also get some beneficial effects on the endothelial function in stent patients, so less accumulation of those plaques on the coronary cells, and some potential benefits in stroke and MI. Now, one of the learning objectives for this, and I want you to be able to take home from this lecture particularly, that certain diabetic drugs will not just have a benefit on your blood sugars. So we'll talk about drugs, of course, that will include your weight, lose weight on them, effect on it. Some drugs can gain weight, these polyurethanes, thiazolidinediones, etc. But then also cardiac outcomes. I want you to pay close attention to drugs that will improve some of the cardiac outcomes. Here, I'm saying that pioglitazone can help for secondary prevention in patients who had a history of stroke or TIA. So there is a beneficial cardiac outcome there. When we get to the other agents, though, you'll see even more impressive results as far as cardiovascular benefits.
Are the effects like good enough on like cholesterol levels that you could, if somebody is diabetic, that you could just use this agent? Or
No, not really.
It's really.
We're talking just a few points on the benefits on HDL or triglycerides. If they are, if they have significant hyperlipidemia, you're still putting them on a statin. With one of these agents, but we're not talking about, by themselves. Yeah. The panacea for these. Here are the contraindications. If they have existing congestive heart failure, class 3 and 4, we should avoid this agent. Can decrease bone density and can worsen steatosis of fatty liver. And really, nowadays we consider these a second line or adjunctive agent. Again, not the most convenient way. It has kind of some benefits to the pharmacology. It takes a while to work. For those reasons, it's really more of an adjunct. I'll very quickly cover these alpha glucosidase inhibitors. This is the drug that works in the GI tract to basically prevent absorption of glucose. So if you have a huge oral glucose load, you just get less absorption of it as a result of these drugs. Again, these are like the propaganide and teglanide. These are prandial agents you take up with a meal, and as such, get less glucose absorption when you have meal with it. Inhibits amylase and glucosidase in the intestinal brush border, thereby reducing glucose absorption. They basically have very minimal systemic effects. In fact, acarbose is not even absorbed at all. There is minimal absorption for miglycols. Recommended to be taken with the first bite of each meal. Miglycol can affect the liver function as well, and these are used in combination for again, their effects are most of them pain. Here are the side effects again. They're not systemic, so you'll see mostly in GI, abdominal pain, diarrhea, flatulence. Because of the undigested carbohydrates in the colon. So again, because of that mechanism, GI pre-existing GI conditions like IBD and GI obstruction is the problem. Interestingly, if you have hypoglycemia while on this drug, you need to correct it with simple sugars like dextrose and not sucrose. Sucrose would not be broken down into dextrose because you have the drug on board that interferes with cannabis. With all that being said, these are minor players in type 2 diabetes because of their modest therapeutic safety outside. So now we get to the real interesting drugs, the incretins, incretin mimetics. But in order to explain how they work, I have to know the underlying endocrinology of it. So when we say incretins, we're referring to these intestinal peptides that are released in response to glucose in the food. And the two main players here are GLP-1, which is glucagon-like peptide 1, and GIP, which is gastric inhibitory polypeptide. So basically, you have a meal, insulin, the glucose and the lipids from the meal will cause a pulse release of these peptides. They act on numerous parts of the body, in the brain, in the liver, kind of help with the process of digestion, but then also signals back to say, you know, as a break to appetite. It helps kind of plays a role in terms of preventing kind of overeating and overindulging, overshooting with those. So they're kind of these regulatory hormones that will typically, if things are functioning well, assist in glucose regulation, digestion, etc. They will secrete insulin and allow for that glucose load from the diet to be taken up in tissues. And in fact, the GLP-1 in particular is only going to have a short half-life of about 2 minutes. So you get the secretion, it's broken quickly down within minutes by an enzyme called dipeptidopeptidase 4, DPP4. Let's stick a pin in that, DPP4. So again, GLP-1 works all over. It's not going to be in the circulation for a long period of time, but when it's there, it's really doing a lot. I mentioned the brain. It has benefits on suppressing appetite. There's some neuroprotective effects which are independent of kind of this whole glucose and metabolism thing. And there's all sorts of research where this neuroprotection is and the effects of GLP-1 on like other addictive behaviors like gambling and alcoholism, etc. This is probably not something we're going to see for another 10 years, but if something comes out, remember that. Anyway, GLP-1 also works in the stomach. It slows gastric emptying, gives you a feeling of fullness for a longer period of time. In the pancreas, it does a whole lot. Increases insulin, decreases glucagon, and increases the proliferation of beta cells, increases the death of beta cells, apoptosis. So all of those effects cumulatively will tend to promote insulin, better glucose control in the pancreas. In the muscle, increased glucose uptake and storage. And very good. Likewise in the adipose tissue. Then finally, the liver tends to suppress glucose production. And there's some cardiac effects as well. That in it as well. So, all of these things, the accumulation of all of these things, it's all beneficial. All beneficial. We should put it in the drinking water. It obviously has some limitations. It's a peptide. It's broken down very quickly in the body. So, pharmacologically speaking, if I were to synthesize GLP-1 and just inject it in you, you will not really have dramatic effects because, again, it's very quickly in and very quickly out. The other ingredient is GIP, gastric inhibitory peptide. Likewise has benefits, the same thing we see in the pancreas and the adipose tissue. In the bone, though, it can increase bone formation, increase bone absorption. And then there's some benefits in the brain as far as increasing progenitor cell proliferation. But GIP is another ingredient. Does not affect gastric emptying in the way that GL does. But, bone remodel, that might be the thing. So you have that. So again, in type 2 diabetes, you have diminished level of insulin, or effectively diminished level of insulin, as well as a decrease in GLP-1 induced insulin secretion. So basically, you don't get that pulse of insulin after meals in the same way as non-diabetics would. In fact, they may have more glucagon, which can perpetuate even more hypoglycemia postprandial. What GLP-1 will do is suppress glucagon, postprandially decrease glucagon during fasting, and increase, but it will slow gastric emptying. What that will do is you get less of a bolus of insulin, I'm sorry, glucose after meals, because it will kind of slow the GI transit, get less of that peak, it flattens that out. It increases satiety, both because of the slow gastric emptying, but as well in the brain. You have signals from the brain that will say, okay, I'm full, I don't need to eat as much. So we have those benefits as well. And again, pharmacological, it means this gives GLP-1. We can't do much. So we have to develop analogs of GLP-1, meaning modify the peptide so that it resists breakdown by this DPP4, which will tend to shorten, which will cause its half-life to be minutes. Okay. So if we can modify the GLP-1 in a way where it resists breakdown but still activates the receptor, then we have a blockbuster. Okay. The other process we can use is to inhibit the DPP4 enzyme. So there, your naturally occurring GLP-1 will just last longer because DPP4 is inhibited. DPP4, of course, is the main pathway that breaks down your endogenous, your own GLP-1. So here, agents in this class, the first was exenatide by Yetta, introduced in the early 2000s. But then once they figured out that this can be a viable mechanism, they basically, again, just took different modifications to that GLP-1 peptide and put it on steroids, basically. So you had liraglutide, victoza, dulaglutide, Trulicity, lixisenatide, and of course semaglutide, which is Ozempic and Rybelsus. So these are all agents that are available for subcutaneous injection. Rybelsus is kind of compounded in a way where it can be given orally. So you have semaglutide injectable, which is Ozempic, semaglutide oral, which is Rybelsus. And Rybelsus, again, it resists GI breakdown, although its bioavailability is still crappy, but it's enough there that you can take it by mouth. The newer agents, semaglutide, dulaglutide, you can give once a week. Exenatide, when it first came to the market, that was the first of them. It was a twice-a-day drug, so you can see they really on a way to making it these longer and longer acting agents. So, so really the ones that are used most frequently nowadays are once a week. So again, it activates the GLP-1 receptor in the same way your endogenous GLP-1 works, but there are amino acid modifications in a way that resists degradation by DPP4. You have a longer half-life than your endogenous GLP-1, so much so that some of these can be given once a week. They will work in all of the same target tissues that your endogenous GLP-1 works. So in the pancreas, beta cells, increases insulin synthesis and release. In the brain, it has the same signaling to suppress appetite, signal fullness in the stomach, that sort of thing. In the peripheral nervous system, slows that gastric emptying, peristalsis. The heart and vasculature, they have benefits there as well. And there are receptors as well in the kidney, the lung, the GI mucosa, and the thyroid. Some of these, not all great effects here, but really the sum total of most patients is going to be really dramatic improvements in there. But glucose control, and as you probably are aware, there are excellent weight loss drugs as well. So the outcomes for diabetes, decreased glucose and hemoglobin A1C. For body weight, it will be decreased, particularly for semaglutide, but even Trulicity and some of these other drugs are pretty good in terms of weight loss. They've been shown, here we go again with the cardiovascular outcomes, to reduce major cardiovascular events, including MI and stroke. All right, so not just the events, but also cardiac-related mortality. So again, this is another one of those drugs with those beneficial effects. And in the kidney, it can increase sodium excretion and decrease oxidative stress. But of course, you can't get all of these benefits without some side effects. If you've ever been on the blogs or in the TikToks of these people that's on these agents, they will tell you firsthand that they, listen, if you were to deep dive on these bloggers and people on Ozempic, you would just waste your life away. It's crazy. But, you know, firsthand, they will tell you the GI is one of the really most significant issues. It will suppress your appetite, and really the worst case scenario cause really bad reflux, dyspepsia, flatulence can be really bad. So you have that. Again, just the slowing of the GI motility can be problematic. Obviously, decreasing appetite can have some cardiac tachycardia, PR prolongation, but again, most of the cardiac issues are beneficial. And then local effects on the injection site reaction. And then there were some animal studies that linked this class of drugs to a thyroid cancer called medullary thyroid carcinoma. So they basically said that in humans, if you have that history, it's a contraindication. I don't think there's been a lot of reports or huge signal in humans yet, especially given that in the animal studies, they usually, I hate to kind of sound cruel, but they will inject these rats with like whopping doses, and then they'll say, okay, well, they get thyroid cancer, you should look at that. So the poor mice will have it. In humans, though, again, not a huge signal, but it's still there in the link. Now, the next step to this, did you have a question?
Yeah, it
Okay.
was just about like with the decreased gastric motility, is that why they're seeing so much issues with like anesthesia and like surgical patients that they need to stop the medications before surgery?
I wasn't aware of that, but it makes sense, because again, it does affect motility. You get, I'm sure, a higher risk of post-operative vomiting and that sort of thing. Yeah, I would suppose that that's probably the reason, or that's what the linkage is,
Okay.
with surgery. Okay, so the next kind of evolution here is to develop a drug that will affect not just the LP1, but the other incretin GIP. And that's where we get tirzepatide Mounjaro. So again, as impressive as Ozempic is, this takes it to kind of the next level. And, you know, so basically all the benefits of GLP, but then adds the GIP effects, which will tend to give you a little bit more adipose uptake. And a little more appetite suppression as well. Like the others, this is a injectable product given once a week, and otherwise has a similar adverse effect profile to the So again, the other mechanism, we kind of stepped back, we said that your endogenous GLP-1 and GIP, or excuse me, GLP-1 in particular, are both broken down by this, that peptidase, which tends to dramatically shorten the half-life of secreted GLP-1. If we were to give a drug that blocks that enzyme, then your own GLP-1 can work. And that's basically what dipeptidase inhibitors do. However, DPP-4 is not exclusive to GLP-1. It also is involved in some other peptides, neuropeptide Y, growth hormone, releasing hormone, etc. So, and then DPP-4 also works in T cell activation with that T cells that express CD26 antigen. So, you know, there's some other potential unanticipated effects that you get from blocking DPP-4, but generally speaking, the benefits is to improve your own body's efficiency as far as GLP-1. Here are the drugs that are in this class: alogliptin, sitagliptin, Januvia, and linagliptin, Trutentia. These are oral drugs, and they're not proteins in the same way as GLP-1s are. So they're oral drugs, they're stable, room temperature, you can give them by mouth, regular pill, and they are often co-formulated with other antidiabetics. So you'll see sitagliptin with metformin, for example. They work, so they will block DPP-4 activity by about a factor of 95% for a duration of 12 hours. So that will at least double your active GLP-1. Again, this is GLP-1 that your own body's producing. It's going to be present at least twofold relative to without DPP-4. What it won't do is affect the end organ sensitivity to insulin. It doesn't have the effects on gastric motility, satiety, or body weight. Not certainly to the degree that the GLP-1 antagonists or GLP-1 antagonists. So really, these are strictly blood glucose lowering agents. You give them type 2 diabetics. You can add them with metformin or sulfonylureas, etc. And it's really acts more of a conventional anti-diabetic. It doesn't give you all of these wide array of other health benefits, but they're excellent anti-diabetics. This is a really good reference. Again, we consider both of these agents, or both of these classes, including the genetics, the GLP-1 agonists, DPP-4 inhibitors. They both will enhance insulin secretion and reduce glucagon. They will cause a reduction in postprandial hyperglycemia, but that's where the similarity is. Gastric emptying much greater with GLP-1 agents, and then all of these other GI benefits and risks would be much greater for the GLP-1s. Nausea, vomiting, appetite suppression, weight loss, etc. DPP-4 are exclusive oral drugs. GLP-1s are pretty much oral. Injectable. The Rybelsus, the oral semaglutide, is an oral drug, but really nobody needs to be on it. It doesn't work as well. It's injectable. Remember over the summer there was this big Ozempic shortage, and the reps were saying, "Oh well, just put them on Rybelsus because they're the same drug company anyway." But no, it's not as good. It's just not as good. You do get antibodies forming against the GLP-1 analogs, not necessarily with a DPP-4. Those are small molecules, and the main risk around DPP-4s is systemic Stevens-Johnson rash. Again, rare, but can be an issue. Whereas GLP-1 can cause some pancreatitis. Genetics that are relevant, they're renally eliminated, particularly alogliptin, sitagliptin. Sitagliptin is also a CYP3A4 metabolite. And then it's cleared via biliary system. They're noted to cause on some patients, a small minority, less than say 2 to 3%. They'll report severe joint pain. We said that the DP3/4 is expressed on certain lymphocytes, T cells, so there can be effects on immune function. And then some of the systemic hypersensitivity shots and reactions. But again, these are very rare. Generally speaking, these are very well tolerated. And then we get to our last group of oral drugs. This is the sodium glucose cotransporter 2 inhibitors. They work on the level of the kidney. Part of what goes on in the kidney, the filtration and reabsorption of glucose. These drugs will favor keeping glucose in the tubules so you pee it out, basically. They include canagliflozin, and empagliflozin, and ersodetropin. Of course, these are all drugs that also are available in combination with metformin. I think this is a pretty cool pharmacology as well. Again, taking advantage of the fact that your kidneys move glucose across its membranes. And there is a co-transporter called SGLT2 that accounts for 80 to 90% of the glucose retention by the kidney. So the thinking is, if you block this transporter, you keep the glucose that's filtered in the kidney in the tubule and not allow it to be reabsorbed, we can just get rid of extra glucose that way. And that's indeed what these drugs are effective in doing. It basically lowers the threshold, okay? You have a threshold whereby if your blood sugar is 180 or above, your kidney will try to force it out through the renal tubules, and it wants to get rid of glucose when your sugar is 180 and above. What these drugs do is reduce that threshold down to 50. So if your blood sugar is as low as 50, your kidneys will still look to pee glucose out. Right? So yeah, that SGL2 inhibition lowers that threshold from 180 to 50. As a result, you get lower blood glucose. You know, if you were to test the urine glucose, it would actually be much higher. And here, we're also seeing quite impressive benefits in cardiovascular and all-cause mortality. Even more so than with the GLP-1 agonists. Think of heart failure patients. In fact, empagliflozin is a drug that's used, think of this empagliflozin, that's used in congestive heart failure in non-diabetics because it is so good at helping with heart failure and long-term outcomes. So that's another impressive benefit here. Now, this drug is only going to be as effective as your kidneys are. So if you have advanced kidney disease, whereby your eGFR is around 45 or less, then it's not going to be as effective. You're just not processing as much urine filtrate as you would be normally. Therefore, the drug is not going to be as effective because it relies on that filtration process. So not as effective. We can use it in lower or more advanced kidney disease. You can get some renal protective effects and cardiovascular effects even at lower levels of eGFR. But really for diabetes, you want your filtration greater than 45. The other problem though is that you have more sugar in the urine. It then becomes a more fertile ground for UTIs and fungal infections. And so you can see an increase in lower UTIs and fibrosis. So you have to monitor, patients for that. You get more diuresis because you're pushing out more glucose into the urine, that can lower your blood volume. Again, that is part of its benefits of intensive heart failure, right? Because CHF patients that have a higher blood volume. But in non-CHF patients, you might not be able to tolerate that. You have to make sure that patients are hydrated to keep their blood volume. There is a risk for hypoglycemia, but it's relatively low, and you can get some effects in terms of parathyroid. But again, generally speaking, these are very beneficial. The blood glucose, the weight, and the cardiovascular. All right, so those are the drugs. Any questions? Just really quickly, yeah.
I feel like there was a lot of buildup. Ozempic, your particular lecture and opinion on Ozempic over the last, I just want to sort of get the main takeaway of, do you find Ozempic to be as dangerous as we keep hearing?
It is an excellent drug for diabetes. I'm going to talk about weight loss drugs in a minute. It probably is the best weight loss drug we have right now. The signal around some of these issues is coming up because so many people are on it. So first of all, I don't think the thyroid medullary carcinoma is a thing in humans with regular doses. But the GI intolerance is a thing. I think that, it shouldn't be used for patients who are really obese. The Kim Kardashian thing where little bit of baby weight or whatever, we should not be prescribing it like that liberally. But generally speaking, I think it's about as safe a drug that we would give for diabetes, meaning that it does have some baggage, but it's not, especially harmful. And again, when you have millions and millions and millions of people on, then you get a signal of some of these things and it becomes amplified. But if you look at it, if millions and millions and millions of people were on the teglanide or whatever, you get the same sort of issue. Just to kind of put it.
For people taking it, are they ever, like, if someone was prescribed it, like, for weight loss, are they ever able to come off of it, or would they just put the weight back on once they're off?
Yeah, generally, it's intended for long-term use. The effects are only going to be as long as they remain on it, because, I mean, if you are really able to implement a lot of behavior changes, that's great, but there's some fundamental impact on your body's metabolism that gets reversed as soon as you stop it. So, yeah, they got you for a long time, and that's part of the reason why it's such a big one. Yeah.
What is the deal?
I,
You had mentioned that they have seen beneficial effects on the beta cells.
yes, so they will actually promote insulin release by just having more hardy beta cells. There's basically, as with any cells in the body, you have a process where they multiply, they grow, and then they die off. It's called apoptosis. What part of what the GLP-1 agonists do is kind of prevent at least some of that program cell death, so that the beta cells are lasting longer. So the net effect is that you will get more insulin release. But there's also other effects in terms of sensitization and some end organ effects in the muscle and all that. So it's really, you get more insulin release, but it also helps with insulin resistance, if that makes sense. So you don't necessarily, if it's just a matter of increasing insulin, that and doing nothing else, as with, say, Ligeride, then yes, you will lower your blood sugar, but you also tend to gain weight with that because you're in a hyperinsulinemic state. Here, you're increasing insulin, but you're also improving its sensitivity and glucose utilization. So the net effect is actually favorable for the overall metabolism.
I was gonna ask, I think you did kind of answer this at the beginning, is that because it also doesn't cause hypoglycemia, if there was any role for it in the type 1 diet, but it doesn't really detect the beta cells as autoimmune issue.
Right,
So-
right. Yeah, I mean, some of these other properties of it may be, but really, a lot of it depends on having a functional pancreas and insulin secretion, so, you know, I mean, in theory, it may have some benefits in type 1 patients, but it certainly hasn't been studied to the point where it's widespread use. All right, so very quickly, these are complications for diabetes. One of the things you have to realize is that you're not just treating diabetes itself. There's a percentage of patients that will develop kidney disease and retinopathy, et cetera. So again, keeping blood sugars under control is the key to preventing complications. There are huge studies that demonstrate this, not just in type 1 patients, but in type 2 patients as well. The cardiovascular, cerebrovascular events. If diabetes, of course, is a risk factor, without those. So we covered this last semester, aspirin and antiplatelets. They're helpful for that. Renal protection. Again, diabetes will, over time, cause declining renal function. And our top choices there are the ACE inhibitors. Diabetic neuropathy. You know, this is not, by the time you get to neuropathic pain, you're not preventing the neuropathy, you're really just treating the pain complications. We used duloxetine, we used gabapentin, pregabalin, and transdermal lidocaine. We covered all of this last semester. And then diabetic retinopathy. Again, this is pretty advanced disease and not much you can do to reverse it, but there's a class of drugs called the VEGF inhibitors we briefly discussed earlier this semester that can help with that particular complication. Just want to quickly cover weight loss drugs because again, in the context of diabetes, part of the issue is weight management. But certainly, this is an intervention that can be done in pre-diabetics and those who have obesity without any blood sugar regulation issues. So really contemporary guidelines are that patients with BMI less than 30 or BMI less than 27 with weight-related comorbidities, those patients should be using kind of a diet and exercise approach first. However, those with the greater BMIs, again, 30 or greater, and generally healthy patients, or 27 and greater with comorbidities, then you can consider weight loss drugs. And then with higher BMI levels, we're looking at your who and why you have to bypass those surgical options. But if you're in this zone where pharmacologic therapy is indicated, your menu basically includes orlistat, which is a fun drug to be on, stimulants. There's a couple of marketed combination products, and then anti-diabetic agents. So starting with over-the-counter agents, you know, you'll see some of these herbal agents, guarana, caffeine, marketed as weight loss agents. Really very limited benefit from those and probably a lot more risk around tachycardia and heart disease and those sorts of things. But specifically, as far as an FDA-approved weight loss agent, you can get orlistat over the counter. It's marketed as Ally, A-L-L-I, and it's given at a dose of 60 milligrams as far as an over-the-counter agent. But if you want to kind of up that, there's a prescription strength product called Xanacal, that's just double the dose, 120 milligrams. Basically, this is a drug that's taken during meals and works by inhibiting pancreatic lipase. Lipase is an enzyme in the pancreas that's involved in fat absorption. Block fat absorption, guess what? The fat remains in the GI lumen and you keep it out, for lack of a better technical term. So there, you get less fat absorption, and over time, you can lose weight. The problem though is, first of all, that fat absorption is helpful or important for fat soluble vitamins, including vitamin A, D, E, and K. So you get less of that, those vital nutrients in your blood, and if you're on Ally or Xanacal, you need to be on a fat soluble vitamin supplement. But then also you get really nasty GI side effects. They describe explosive diarrhea. You know, it's really bad. That is worse if you take a fatty meal on Olmsted. So, you know, you don't go to Fogo de Chao or whatever. Take the Xanacal. It would be embarrassing situation. So you have that. Ally, Xanacal, all of that.
That's all.
That's
You told me to.
a different approach. Here you are suppressing appetite by signaling to the brain. There's a feeding center called the hypothalamic feeding center, where you have dopamine inputs. And basically here, we talked about stimulants briefly last semester, like an ADHD or whatever. One of the issues is that they will suppress appetite. Here, these are stimulants that are specifically used for appetite suppression. According to labeling, they're limited for use 12 weeks at a time. So they would have these weight loss clinics that will have patients come in, put them on a stimulant, really not supposed to exceed 12 weeks. And you get some modest weight loss because they're just less caloric intake. Phentermine is the prototype drug in this class, but there's also bensphetamine, dipropion, and benzodiazepine. Their schedules control 3 or 4 those substances. And as stimulants, they will cause CNS activation, tachycardia, anxiety, insomnia, take it to late day. So yeah, you get that there. They will again give you some modest weight loss because you get less food intake. The next group are combination drugs. These are drugs we've kind of talked about in different contexts. Certainly, phentermine is one of the stimulants we talked about, but then topiramate, if you remember, is a drug that's used for epilepsy. One of the side effects of topiramate is that it causes weight loss. So it has since been developed into this product called Qsymia, which binds phentermine with topiramate, and is a kind of a dual mechanism in terms of increasing satiety and decreasing appetite. You can't just write for Qsymia, you have to be registered as a prescriber. And it's a limited distribution network in terms of pharmacies that you can get it from, mail or whatever. So you have that. And then Contrave, which is naltrexone. Remember, naltrexone is an opioid antagonist. And bupropion, which is a serotonin, dopamine norepinephrine reuptake inhibitor used for major depressive disorder and smoking cessation. Basically here, mild stimulant effects, decreased, naltrexone has effects on cravings. Remember, we talked about naltrexone for alcohol use disorder. So here it's used for food cravings and appetite. But if you have someone with opioid dependence, you can obviously opioid withdrawal, like opioid dependence. And then we have the GLP-1 agonists. Here, liraglutide, Saxenda, semaglutide, it's branded as Wegovy as a weight loss drug. Okay, because Wegovy is not Ozempic, and Ozempic is not Wegovy. But they're basically marketing. Likewise, tirzepatide is not Mounjaro, it's Zepbound. Really, it's the same drug, same manufacturer. They're able to kind of market it differently. In the case of Wegovy and Zepbound, they're slightly different doses. So instead of 2 milligrams, it's 1.8 milligrams or something ridiculous. So again, all sorts of things they're playing with in terms of being able to kind of keep the patent on it a little bit longer. Again, these are multi-million dollar drugs. So, you know, we talked about the pharmacology already. They regulate appetite, caloric intake, signaling in the brain, slowing the GI motility, and we give them once a week via injections. Interestingly, Saxenda and Wegovy have pediatric indications. So the childhood obesity epidemic, which is a thing, you can give these drugs to kids 12 and older, right? Whereas Zepbound doesn't quite yet have a pediatric indication. I'm sure it's coming. And again, you know the GI effects by now. Hypoglycemia can be an issue in non-diabetics. It's an increased pulse and then labor vibration. So that are the weight loss drugs, and I really love this table. Basically, they looked at the studies for a number of the weight loss drugs and gave you a comparison. So, orlistat, the light gray represents placebo, the black represents the active drug, and for 52 weeks, the expectation with orlistat is that you lose up to 6% of your body weight. Right, so that's a placebo. Liraglutide, a little bit more than 6%, which is good. This is semaglutide, almost 16% weight loss after 68 weeks. So semaglutide and liraglutide were longer studies, 68 weeks. You get it close to 16%. And then Qsymia and Contrave, a little bit less. So just puts things in great perspective in terms of effectiveness differences. And then this table kind of goes over the diabetic drugs we covered today and advantages, disadvantages. So this serves as a good review. Briefly last week about animal. So that's the lecture. I have a few cases though. Any questions? Going to this first one, a 32-year-old woman. She has no prior history of diabetes, but she's 29 weeks pregnant. Her fasting blood glucose is between 1 to 10, 1 to 20. So typically with gestational diabetes, you see it in the third trimester, right, as the fetus is maturing. And really the longer the baby is exposed to elevated blood glucose, really the main complications is that you get larger birthing babies, and they will actually have problems with blood glucose regulation. So for gestational diabetes, our strategy for blood glucose control is metformin as far as oral drugs, and insulin for injections. Even if the woman is not diabetic, classically speaking, when she's not pregnant. You have an 11-year-old boy who is diagnosed with type 1 diabetes. Right, so you will pretty much need insulin. Now, insulin in type 1 diabetics, basal and bolus. Basal dosing is with newer drugs, typically once a day, with which products? Lantus, Largine, Lantus is Largine,
There's an A. Oh, this probes. A.
Levemir, thank you, which is also once a day. But in some cases, especially if they're on lower doses, you will give it twice a day. The way that it interacts with the proteins and such, it has a shorter half-life at lower doses. Those are your basal insulins. Your mealtime insulins are Lispro, blocking on all the insulin products, and Novolog.
Something with an
Yeah, whatever you can get coverage for. So the basic approach here is that in newly diagnosed patients, you're going to dose them by body weight. And again, I'm not going to go into the specifics around dosing. I don't hold you responsible for that, calculating dosing for insulin in this course. But the idea is that you will estimate their initial insulin requirement based on body weight, and then take that dosing and make half of it basal in the once-a-day product, and then half of it you distribute over the course of the 3 meals with a mealtime dose. Then you will, ideally get the child and his parent to take a diary, get the blood glucose readings, and then when you bring in the next time, you see, okay, they have postprandial glucose too high after lunch, you can increase the lunchtime, or whatever adjustments you make that are appropriate. So initial dosing based on weight, subsequent dosing is going to be based on data that you get from blood glucose readings. And again, type 1, that's a lifelong approach with insulin. Now, the alternatives to this classical basal bolus dosing, talked about a couple of products like Novolog mix, Accumulog mix, which are mealtime insulins, but have at least part of their products are somewhat longer acting. So by mixing rapid acting mealtime insulin with a kind of a longer acting version of that rapid acting insulin, you can simulate basal bolus dosing, but with fewer injections, twice a day instead of really 4 injections a day. So that's an alternative, but really ideally for tightness control, you're using the once-a-day basal, one of the newer once-a-day basals and mealtime. Question in the back.
Yeah, when you're prescribing though for type 1 diabetics, does insurance, they go straight to like the pod that's giving them insulin?
Some private insurances will allow that. There will still be a little bit more of an out-of-pocket cost for patients, at least initially, but I don't think like Medicaid is covering that for indigent patients, for example, at least initially. That's going to just differ from plan to plan. You can though have some private insurers that will say, we're better off paying for the ambulatory pump, the Medtronic pump, for example, than paying for kidney transplant in 50 years or whatever. So, you know, you have, those, calculations that are made, but, you would have to kind of, individualize that based on the, person's coverage. All right, next we have a 53-year-old, who is diagnosed with type 2 diabetes. His initial A1C is 8.1, so it's above where we want it to be. After attempts at weight reduction, increased physical activity, and metformin, his A1C is down to 7.8. So what can we do here? Basically, metformin is one of those drugs you can pretty much add anything else to. So, you know, you could do quite well with either, say, SGLT2 antagonists. It could be 4 agent if you want to just put them on another oral drug. Sibutramine can still be useful here. And, you know, the combination of those will produce synergistic results to help with that. It might be a little more aggressive, go with the GLP-1 injectable, what have you, but basically, this is a type 2 patient, you have a pretty wide mix.
Well,
Mhm.
can you speak to, the use of dual agents versus maximizing metformin at this point? Only because I know that they've probably heard different things, and your experience.
Yeah, when you have agents with different pharmacologies and you combine them together, you know, it gets back to this concept of synergy where 1 + 1 is more than 2. Okay. We see that a lot in cardiovascular disorders where with hypertensives, you know, you're better off, say, adding ACE inhibitor to 12.5 of hydrochlorothiazide than increasing the hydrochlorothiazide to 25. I have a sense that with diabetes, we see that the same, especially because with metformin in particular, the tolerability goes down the more you increase the dose. So the labeling says you can go up to 2250 of metformin, but you might have a patient say that if you're more than 2000 or 1500, it becomes really difficult to tolerate. So in those cases, adding a drug with a different mechanism to the metformin, which you kind of established maybe at a moderate dose that is able to tolerate, you're better able to get that control. So it's not just, you know, strictly simplification. It's really meeting the patient where he's at in terms of tolerability. And, you know, you have to kind of consider that. If it's something where multiple drugs, you know, it's gonna lose your ability to really comply with the regimen, that sort of thing, then you have to kind of rate that as well.
Thank you so much.
And then finally, you have a 62-year-old with long-standing type 2 diabetes. He's been non-compliant to lifestyle interventions and medications until his heart attack 1 month ago. Now, he's slightly overweight, has mild renal insufficiency, but he's committed to following the treatment plan. So it's nothing like a heart attack in some people, and I mean this in all seriousness, that will kind of be their wake-up moment, you know? So now you have someone that's a little bit more committed to following their treatment plan. What are your thoughts here? Yeah, I like the SGLT1 for this guy because he's had the heart attack. We want to have something that will give you benefits for the cardiovascular outcomes. The renal insufficiency we're calling mild. So I'm assuming he's still at the cutoff or above the cutoff to where his renal perfusion will support using this drug for blood glucose lowering. Okay, if this mild renal insufficiency is, oops, I need to advance the slide here, sorry. If this mild renal insufficiency is more like moderate to severe, then no, it's not the best option, but mild renal insufficiency, we can still use finagliflozin, for example. And, has benefits for weight as well. So I really love that for this person. And again, this can also be a candidate for, SGLT1. Sorry, GLP-1 analogs. And then I'll get emails over the next week, which is fine, and I will, try to address those, and I'll, leave some time